Hi. A little while ago, I made a couple of films discussing the complex relationship between pacing, pushing, and autonomic conditioning. Well, in this film, Dr. Asad and I talked to the expert, Jenna Tosto-Mancuso, a physical therapist and the clinical director at the Abilities Research Centre at Mt Sinai. In this video, the first of two, we ask her about what the principles are behind autonomic conditioning, whether it's suitable for everyone suffering from long COVID, and exactly what it might involve on a practical level. So, hi, Jenna. Thank you so much for joining us. It's an absolute pleasure to talk to you. I was wondering if we could start by, if you could just tell us briefly a little bit about some of your professional history and how you came about treating long COVID patients.
So professionally, I am a physical therapist. I am also a clinical specialist in neurologic physical therapy. My background as a researcher began in autonomics, largely investigating cerebral blood flow and cerebral blood flow autoregulation. And really what that passion and interest morphed into and evolved into is a passion for technology and innovation in rehabilitation clinical practice. And so really starting with that experience and that patient experience, again, working with folks with a myriad of different neurological disorders, those passions merged in, and I found myself in autonomics. Once again, really at the peak of the COVID-19 pandemic. The group that I work with, I am currently our clinical director at the Abilities Research Center at the Icahn School of Medicine at Mount Sinai here in New York City, which very, very quickly became the epicenter of the COVID-19 pandemic in March of 2020. And what we quickly started to learn about patients with acute COVID-19 is that there was a subcohort of folks who just were not getting better, and their symptom presentation was different than their acute symptoms. And we started really picking up on the signs and symptoms that started to indicate that this was in fact related to some degree of autonomic dysfunction, perhaps. And really from there, my group and I, both on the clinical front and the research front, have largely been passionate about providing care and further investigating long COVID. So it's been an interesting road to get to this point, but I'm so grateful for the opportunity to help.
It would be useful to hear, perhaps in simple terms, of what autonomic reconditioning actually is.
When we think about the autonomic nervous system, the way that I think about the autonomic nervous system, it's a really broad-based system. And so in its purest sense, we're thinking about the automatic functions of our body, right? Modulation and management of our fight and flight, our rest and digest functions, which when we think about each individual body system, the autonomic nervous system at some way, shape, or form impacts it or touches it. And so when we think about autonomic reconditioning, it is a very symptom titrated, methodical approach to rehabilitation, really putting symptom management and strategies like pacing and energy conservation at the center. It's a very collaborative approach to rehabilitation that's aimed at upregulating the tone or the responsiveness of the autonomic nervous system. And so how that's done is in a collaborative fashion with a rehab provider, starting to understand how very, very gentle based movement, breathwork exercise can start a patient who perhaps is not tolerating traditional forms of activity or movement and allow us to open a window and open a door to movement in that sense. So again, at its core, the concept of autonomic reconditioning is that of symptom titrated introduction to movement with the overarching goal of improving the sensitivity and regulation of the autonomic nervous system.
And is this appropriate or effective for all long COVID patients or a subset? And how do you differentiate between those who it might be useful for and those who it might not?
So I think a really important thing to consider when someone is considering either participating in autonomic rehab or beginning an autonomic rehab program, or for providers deciding who is an appropriate candidate, really is symptom stability and symptom titration. And so the idea that first it's paramount that we understand symptom presentation, perhaps getting a better feel for the trends of the symptoms, what are exacerbating factors, what are helpful factors. And then from that point, starting to understand what are factors that help us to stabilize symptoms. So for the purposes of autonomic reconditioning, I generally will start folks off with a preconditioning program or a quote unquote prehab, where we'll do things like breathwork exercise, diarying and journaling to better understand symptoms and symptom trends. And really from that point, if we can start to better understand that process, that's usually the point where I'm comfortable starting an autonomic reconditioning program. So I don't think, and I think it's so important to underscore that autonomic reconditioning is not a one-size-fits-all approach. It really is individualized. And I think when we take that into consideration, we can start to better understand who might be a good candidate and when someone might be a good candidate to start.
Might be a good time to start this once the acute illness has stabilized and the patient has established long COVID. I mean, clearly some people are quite debilitated. Is there a place even then for some gentle reconditioning? I'd be interested in your thoughts.
I think there is. And I think where this comes in again is this idea of symptom titration. And at its core, that principle really is a matter of understanding the symptoms and modulating and changing and titrating our reconditioning approach to be sensitive of those symptoms. So something I tell every therapist and clinician who I meet with and discuss and train on autonomic reconditioning, this concept of pushing through symptoms or just tolerating exacerbations of symptoms, that does not apply here at all. Really what we want to start to do, even for folks who have very severe, very significant symptoms, we want to introduce movement in a way that is respectful of that. So I oftentimes will educate folks on what's called an RPE, or a rate of perceived exertion scale. And so there's a standardized scale. We use a modified one that's a 0 to 10 scale. And we want to make sure that we're keeping symptoms or keeping exertion at a very low threshold, a 1 or a 2 on the 0 to 10 scale. Similarly, we emphasize something called a VAS, or a visual analog scale, where we educate our patients to understand where their symptoms may fall in this VAS. And if we find that with activity and with movement, both in session or while someone's doing autonomic reconditioning, and even in the hours to days later, that symptom should start to worsen, or their VAS, or the perceived symptom severity is worsening within the scope of that scale, that really is information to us as providers to scale the interventions that we're providing. So I do think that there's a way that across the trajectory and across the road to recovery for folks with long COVID, we can introduce autonomic reconditioning. We just have to be very sensitive and respectful of that.
On the understanding that no two cases of long COVID are the same, everybody is different. If you were to say what your typical patients might present with in terms of what the few symptoms are that indicate they'd be a good candidate for autonomic reconditioning work, what would those symptoms be? And then what would the kind of movements look like that you might be asking them to do, and how would those scale up? So we can just get a picture of actually what would it involve.
Absolutely. So what does the concept of autonomic conditioning look like? Or what does a candidate for autonomic reconditioning look like? So typical symptoms that we see, and I think we're starting to see emerge in the literature that autonomic reconditioning has the capacity to move the needle on, symptoms like fatigue, endurance deficits, orthostatic intolerance or positional intolerance, dizziness, general autonomic symptoms, things like thermoregulatory differences, GI symptoms, etc. So anything falling under what, again, we perceive is being mediated by the autonomic nervous system, which again is a very, very broad system, but nevertheless, we can start to parse out a bit more directly what symptoms may be related to that. Typically, those are the patients who we find are good candidates for autonomic reconditioning and respond well. And so how we typically will start an autonomic reconditioning program once the patient has progressed through a prehab or that breath work exercise early on in their rehab, we'll start with supine-based activity. And I'm always extremely conscientious and extremely adamant about pointing out that it's not under the guise of exercise. And so I always want patients to understand that introduction of movement is meant to be quite literally that, just an opportunity to start moving one's body in a way that feels safe and supported. And so we'll have folks start in the lying down position or the supine position. And some sample movements might be something like a heel slide, where an individual is sliding their heel up and down a mat table. Key components of autonomic conditioning, a across all positions, and I'll discuss a bit more what those look like in terms of progression, but key differences that help to drive autonomic reconditioning. The first being the way that we do the exercise program in general. So never will I tell someone to perform their movements in steps and repetitions. So, in a traditional rehabilitation setting, one may be told 3 sets of 10 as the prescription of the activity. And the reason I steer clear of that is because I think that sets an unrealistic precedent about how much exertion one is responsible for doing. So instead, I like to use time-based intervals for autonomic reconditioning. So I'll ask a patient to perform a set movement over the course of 30 seconds. In that 30 seconds, if they comfortably achieve one movement while still maintaining that lower RPE or rate of perceived exertion, that's great. If they achieve 10 movements in that 30 seconds, that's also great. There is no set number of repetitions. And really my goal with that is to help individuals start to understand their tolerance and their perceived exertion, because that I find to be incredibly important in modulating and taking into account things like post-exertional malaise or post-exertional symptom exacerbations. So again, doing things in time-based intervals instead of sets and repetitions, really driving in and honing in on the rate of perceived exertion scale, as well as that visual analog scale of their symptoms. So folks will start off with their lying down exercise. And generally, I like to find a point where folks are tolerating those 30-second intervals well. They're typically performing 4 or 5 movements in that supine-based progression. And then from there, we'll have folks progress to exercise or movements in sitting. So making sure that we are having folks tolerate the upright position. From there, their movements will progress to standing. And then from there, we can start moving into more endurance-based training, things like overground walking, use of a recumbent bike, etc. But it's all really a progression based on symptom presentation and symptom tolerance.
When you start to improve and you feel like you can do a bit more, it's really hard to actually assess what the right amount of exertion is. So I really like what you said about movement versus exercise, because the moment you hear the word exercise, there's a certain visceral reaction. So I think that distinction that you made is really, really key, and hopefully will reassure people.
Hope you found that interesting. In the next video, we'll cover whether it can help other forms of dysautonomia like GI issues and temperature regulation, what kind of improvements might be expected from autonomic conditioning, and which symptoms it can help. Until next time.